There you
Now
go.
you hear me.
Perfect. Yeah, we can hear you. Very good morning, Dr. Friedel. I'm Dr. Mu I'm Dr. Mu, also medical psychiatrist, and Mrs. Oñate wanted me to acknowledge your talk, to do a brief introduction to you, and of course to show you our gratitude. It is very, very good. And by the way, Teresa was giving me the message that she has already bought your book, and she's more than happy to share it and to learn a little bit more about the borderline personality disorder. It is an honor for us to have you here.
It's a pleasure for me and an honor too.
Thank you so much.
I have spoken in Spain before at
Okay.
a psychopharmacology meeting that was set up by one of the pharmaceutical firms.
Okay.
It was about 20 odd years ago. It was in Barcelona. It was a lovely city.
It is. I work nowadays in Barcelona after more than 12 years in Madrid. Very, very good.
Enjoyed my trip very much.
Very, very good.
I'm delighted to be with you this morning.
Okay, yeah, no, but it was very, very difficult due to the COVID-19 situation everywhere. It's absolutely amazing.
Yeah.
That's very good. You may start whenever you want, Dr. Friedel. Will be a pleasure.
How do you want me to start delivering when?
Whenever you want. We're ready because.
Are you taping this?
Yeah, we're taping this, and by all means, the translation is working correctly as far as we know.
Okay.
So no problem. You may go ahead. Welcome.
Yeah, please. Sorry, just one message for the audience. Si alguno quiere escuchar la interpretación en español, por favor, si sois tan amables, tenéis una bola del mundo abajo, en la barra inferior de la pantalla de Zoom, que pone interpretación. Tenéis que hacer clic ahí y seleccionar español o inglés, el idioma en el que estéis más cómodos. Muchas gracias. Thank you, Doctor. Please go ahead whenever you want. Many thanks.
Good morning, ladies and gentlemen. I'm Dr. Robert Friedel, and it's a great pleasure for me to be here today with you. I've been invited to talk about the major events that are occurring in the field of borderline personality disorder in the United States. As I've thought about that topic, there seems to be one major problem that we are having, and I don't think is strictly occurring in the United States. I think it's happening around the globe in other countries as well. Surprisingly, although we have not had very good treatments for borderline disorder until the mid-1980s, now that we have two different approaches to the disorder, both therapy, psychotherapy, and psychopharmacology, we seem to have, rather than advanced tremendously, which we have, there seems to have grown if you will, some kind of a dissension between the therapists and the people who prescribe medications. From the time that we published our first paper on medications, receiving a somewhat cool response by one of the major therapists in the world and refuting the use of medications for borderline disorder, until now, the problem does not seem to have lessened very much. So my intent today is to share that with you and hope that that indeed over time, and it may take a generation or two to solve this problem, because it's very similar to the problem we had with schizophrenia and bipolar disorder 2 or 3 generations ago when I began my training in psychiatry. There was a significant, I won't call it angry, negative response towards the conception that schizophrenia was a biological disorder and an inherited one. That was not received well. It was still thought that and the environment caused the disorder, what was going on in the environment. For example, the most common um, guilty people were unfortunately the mothers, because they presented their children with conflicts, what we call double binds. You're wrong if you respond yes, and you're wrong if you respond no. And that double blind places them in a terrible position. And they have difficulty, of course, with that. And they eventually grow to have schizophrenia. That is not the case. And those poor mothers, when you think about it, there they have children and adolescents who have schizophrenia, and they're beside themselves with worry and problems, and they're being attacked for causing it. That's a bit unseemly and not right at all, of course. Well, the agenda we're going to follow today is I'm going to briefly describe borderline personality disorder, what it causes, and how it's best treated, and define a little bit more clearly then how I see the problem here in the United States. And if I have time, give you a brief case example that shows how I think the problem can be solved, which is to integrate the use of both medications and therapy, because they both play different roles in the treatment of the disorder. And do so by giving a small case example. And then finally, we had scheduled some time for questions and answers. We'll see if that can be arranged and it still happen. But if it doesn't, we'll deal with that some other way. All right, let's get started then. Borderline personality disorder is a moderately to severely disabling mental disorder with a suicide rate of 9%. The prevalence of disorder is anywhere between 3 to 6%. That's a staggering amount of people. If you round that off to just 5%, that means 1 out of every 20 adolescents and adults in this country have borderline disorder. And I say adolescents because the most common time period of life when borderline disorder evolves to its adult form is in the adolescent years, which is tremendously disabling for the child or the adolescent who has it, and also very disruptive in the family. Let me share with you quickly that I had a sister a year and a half younger than I who had borderline disorder. And she was a wonderfully pleasant girl and then young lady when things were okay. But when the effects of the disorder occurred to her or happened to her from time to time, as they would, of course, she was a different person. We couldn't deal with her. Her anger was enormous. Her inability to reason was great. Her relationships with all of us deteriorated terribly, and she was enormously impulsive. I say that because having lived with someone with borderline disorder, I think I have a sensitivity to that, people with that illness, that has helped me to better understand what is going on with them, what kind of a life are they leading, and what's going on in their heads, so that I can address the problem with them forthrightly and tell them that this is a medical problem. This is not that they're a bad person, and then give them some guidance about the treatment that we have now that will allow them to lead a much more normal life and achieve what they're truly capable of achieving. Many of them, of course, just like the general population, are quite bright. And then there's the average person. And then there are people who are not quite as up to date with things and don't have the latent inherent talent. But that's the way it is for all of us. But they should have an opportunity to live up to their potential. And that's that's, I think, the goal of most of us who work with people with borderline disorder. The criteria for borderline disorder, according to at least the Diagnostic and Statistical Manual of the American Psychiatric Association, consists of 9 criteria. And on the slide that I hope you're seeing now, you can see the criteria, and there are 9 of them. If you look on the left, you'll see that there are 4 dimensions to the disorder. There is an affective dimension, and let's see if I can get that up here. Yes, there's an affective dimension, and there is a, would you be able to put on the original or leave that off and let me see my original slides, please? I think I can do better from that. Good, thank you very much. The affective disorder is one group of 3. And you'll notice something strange. These numbers are out of order. Well, that's simply because the people who developed the symptoms of borderline disorder as the key ones and developed them in the order that had nothing to do with the dimensions. And the dimensions have come to be understood as 4 groupings that are much easier to remember and for patients and family and clinicians to relate to. So one is affective, and you can see what the symptoms there are, especially the affect, which is a major, the anger, which is a major problem there. Then impulsivity, and 2 criteria are demonstrate the significant impulsivity that people with borderline disorder have. Self-harmful in 2 ways. One is less self-harmful, spend excessive spending in sex and so on. And the second is quite harmful, either the self-damaging acts, self-mutilating behavior, or suicide. And then self-image. People with borderline disorder have an identity problem. It's hard for them to truly understand who they are, where they fit in the world. And they have trouble thinking logically and in a stable manner. So if you sit down with them when they're not doing well, they're enormously difficult to reason with. And also they become quite paranoid at times over a very little incident. You may not even know, as a family member or as a clinician, what the issue was that drove them to this level of suspiciousness and paranoia, but some little thing triggered it. And then finally, the interpersonal symptoms, which interestingly were the first 2, the frantic efforts to avoid abandonment. Let's see, I've lost the, can you return my slides to me again, please? Get off the screen then. I don't know why we went back to the others. No, I need to have my slide. If you just remove your slides, the ones you have from my screen, my slides are on my screen and I can better talk from them. Can you remove the slides that you have from the screen that's in front of me? Anyway, while we're trying to do that, let's move on to the second issue, which is what causes borderline disorder. Here we have a very prevalent, very disabling, and a potentially lethal disorder. And how in the world are we going to understand what brings this on? Of course, not surprisingly, once again, the thinking was that This was caused by poor parenting, mothers that were not very comforting to their children, put them in catch-22s again, famous catch-22, that they were abused frequently with sexual abuse, but also by physical and verbal abuse. So there was, it was considered to be environmental. That's not true. We now know that borderline disorder is mainly an inherited disorder. 55% of the risk of developing borderline disorder is a result of genetic influences. Some of the symptoms we just went through are have more latent or inherent risk factors. For example, the affective problems, and to some degree the self-understanding, reasoning, and so on, paranoia. And others are more, if you will, develop secondarily to those, and they have more environmental type loadings, although they all have loadings from both areas. That is, they all have risk factors that stem from genetic and from environmental. Interestingly, it appears that the genetic risk factor that's the most common and the greatest affects every one of the 9 symptoms. And that's been shown just recently, in the past 5 years or so, in studies. Let's see. The importance of this, by the way, to treatment is that, as you would expect, it appears that in research trials, medications seem to be more effective for symptoms such as the anger and the impulsivity and the cognitive problems than it is the other symptoms of the disorder. So you would then expect that for the patient to get well and benefit from psychotherapy, the anger and those symptoms that are due to biological causes have to be reduced, have to be brought under control, or else they just don't improve very much, the environmental ones, because it's very hard to learn from a pill. There's no information in a pill. That has to be explained to you. You have to understand it and struggle with it in therapy. And that takes quite a while. But you cannot struggle with it effectively if your brain is not working well. It's not reading the environment correctly. It's not reasoning well. And your emotions are not under good control. So it's very important to understand what causes this disorder if we're going to think about a rational way to bring good therapy, effective, when I say therapy, I mean treatment, to people with the disorder. It's very interesting, by the way, as we're talking about genetics, this is not all or nothing either. This is not black and white, heredity versus environmental. They interact. And so, for example, there's a very peculiar occurrence of symptoms that seem to be transmitted to children that are peculiar in a given family. And one wonders, how can that be if it's genetic? And that's not only that the children seem to have that, their children seem to have it. So it's somewhat as if they have a genetic problem. And indeed, they do have a genetic problem after they've been raised with the problems of borderline disorder. The way this happens is a very interesting chemical event, and it's called epigenetic mechanisms. And what happens is that if there's an area that has to be handled differently by people with borderline disorder, it can be enhanced or it can be reduced simply by adding, for those of you who have some chemistry in your background, by adding a little methyl group to the DNA. And as you add or remove it, that gene and the genes who have that methyl group on them become more or less active. That's an amazing process, so that how you are raised, regardless of whether you have borderline disorder or not, that's true anywhere. And it makes good sense, because if you're raised in an environment where athletic skills are really the most important, or you don't eat, then you better develop those. And the same is true if you're, if you will, educational. Academic skills are most highly needed, then you have to develop those, your ability to read, write, arithmetic, and so on. So that makes sense in terms of the resilience of the species, as Darwin would predict, and it surely works out that way. Okay, let's move on. Can you bring up, or again, if you could remove this slide, it would be very helpful. Just, can you remove it from my screen? I know you have to show it on yours. But again, remember that the genetic factors are strong, stronger than the environmental for developing disease. The importance of that is that you don't give someone borderline disorder any more than you, by the way you treat them or by the way they eat, they develop diabetes. That just doesn't happen. You have to have the genetic susceptibility to it before the environmental influences take hold. Now let's talk a little bit about the therapies. We now have two effective ways of treating people with borderline disorder. The borderline specific psychotherapies, especially a couple of them like DBT and MBT, are probably the most used internationally. Depends on the country, but those are the two. But if they're not, then there are four others types of therapy, which you can see on the screen, transference, focus therapy, etc. The interesting thing is that no therapy has been shown to be more effective than another. They may be more effective on one of the symptoms or two of the symptoms than another, but they're not more effective overall in treating the disorder. But again, that's true for medications. Medications are not as effective in some areas as therapy is, but they are much more effective in other areas. That's an important concept to grasp, given where we're going to go with this. The major medications or classes of medications that have been found to be effective, most effective with people with borderline disorder, are second-generation antipsychotic agents. For example, I'm not sure what the brand name is in Spain, but in the United States, it would be olanzapine. That's one of them. Then another one is that's been used frequently is, let's see, then I would say the next one is Abilify, aripiprazole. And then another one is risperidone or risperidone, depending on whether you use the brand or trade name. And almost all others, surprisingly. So it's been really only one of the first generation or second generation that has consistently been found not to be effective. So that's a very effective group of medications, but they must be used in a specific way. And we'll get into that in a few minutes when I go through a case study. It was thought initially that SSRIs, like Prozac and so on, were effective in treating borderline disorder. And the guidelines from the American Psychiatric Association in 2001 stated they probably were the most effective. Well, that turns out, both of those issues turns out not to be true. Antidepressants work only in borderline disorder when the person is suffering from a coexisting depression. If they're not, and not a borderline depression, not the brief depression that's brought on by having a close partner leave, abandon them, or losing somebody, a person dies that's close to them, a parent, for example, or a spouse. Then that they can go through a very, if you will, brief depression, which is not a typical major depressive disorder. But that needs treatment with borderline disorder approaches. So there's that important difference between depressions with borderline disorder and depressions that are secondary to it. The next are mood stabilizers. The first ones used were, Depakote, and then others came in, Lamictal, lamotrigine, which seems to be more effective in treating depression factors that come with borderline disorder. Benzodiazepines were initially thought to be very helpful. There have been a number of studies now that show that's not so, especially when used in more than very, very modest amounts and when used more than irregularly. Because what they do is to release the control factors in the frontal lobes and allow the impulse and emotional and other factors which stem from the limbic system, especially the amygdala, they lose control over those. Whereas we're able to reason out quickly, no, I may feel very angry about this, but I'm not going to respond that way because that's not really appropriate. This person needs support, they need help. They don't need me to be hollering at them. So they're probably not as effective. There have been other medications that have been tried once or twice and found to be effective. However, there is one class of antipsychotic agents which have not been used, and that is clozapine, in our country, clozapine. And because of its tendency to cause physical disorders can be high, especially white counts, blood counts. It's people have stopped using it even for schizophrenia, at least in our country. But that has been, we've gotten around that by setting up a, if you will, a control system that requires that if someone's going to use it, they have to be licensed to use Clozaril. They have to pass certain tests, and they have to do certain things on a regular basis to keep them abreast of what's going on in the field. Interestingly, people in Great Britain have used it for people who were sentenced for violent criminals who were could hardly be controlled in a jail cell, but more than the majority of them, let's say the majority of them, could be released when they had served their term and released in good condition. They were suffering from borderline disorder, or some of them were suffering from schizophrenia, but they could be helped. And but that's shunned by a number of people, even those who use medications for borderline disorder. I've used it about 4 or 5 times for patients, almost all of them adolescents, who could not be effectively treated with any other medication, and certainly not psychotherapy, because of their behavior being so violent and so out of control. And it has yet to not work. It's been safe. We've checked blood levels regularly. We've looked after them regularly, made sure the doses were right. And they respond very, very well to very low doses of the medication and are able to return home again. I had one young man who, 15 years old, who attempted to throw his mother downstairs when she did something that made him angry. And fortunately, the father was standing right there, her husband, not the father, but her husband. He was adopted. And he stopped the boy from doing this and then vowed that he would never be returned to their home again because he had been adopted a year or 2 before. Well, it was under those circumstances that when working in a partial hospital program treating adolescents that I came across this boy, made the diagnosis of borderline disorder. And when all of the other reasonable antipsychotics did not work, I requested their permission. He was 15 years old, requested their written permission to use this medication, having discussed the potential problems. And the father and mother agreed, but the father was relentless. He said, I'll still not let him back in the house. Well, he recovered to the degree that a year later, when I called to check up on how he was doing, he was being followed in a different city after he was released from our facility. The father said, he's not only doing well, but it turns out that I was totally wrong about not letting him back in the home. He's been back in the home now 6 months, and he's been doing just splendidly. So again, it demonstrates the power, if you will, of the appropriate medications to help people who, without them, would have to be locked up until we understood that we had treatments that did work. And we've already discussed the SSRIs, not effective, but they're commonly used. By the way, 90% of people with borderline disorder who come into psychiatric clinics have been treated with some medicine. Typically, it's the wrong medicine, but that's okay in a sense, because at least the doctors are not afraid to give them the medication. What they're given are SSRIs, which don't work because they're following the old guidelines and they're not up to date with the new guidelines. And they occasionally get second-generation antipsychotics. But at least they're getting some medication and there's not the great resistance to it. Now, there are research studies that are, if you will, the golden measuring stick for determining whether a medication is effective and or is it harmful, does it have side effects? And those are called random controlled trials, RCTs. And there have been now more than 30 random controlled trials with medications and about 100 with psychotherapy. Most of the ones with psychotherapy have fallen in the area of DBT, and they are same size studies as the medication studies, but when you group them all together and you do what's called a meta-analysis, that's a analytics analysis. When I say analytic, it's a statistical analysis that can be even more precise in its results, has shown that indeed the psychotherapy is effective in some areas. And that, which is good news, of course. We want the more RCTs we can get, so we can get some of these medications approved by the FDA in our country, which so far they haven't been. But my guess is it won't be long before they are. And the only problem with the RCTs is, although they call themselves random controlled trials, they're not complete random controlled trials, because the patients who are used in those studies have all received and continue to receive medications throughout the course of therapy. Now, the only thing they do is they don't record how much they're receiving specifically. They never mention that in the paper that they write. But whatever it is, they continue to receive it. They just can't have it increased. But most of the people in those studies are receiving medications. So it's very hard to tease apart the effects of medications, of course, if you don't control for it, and therapy. So when it's effective, does that mean that the medications are doing it, or that only the therapy is doing it? Of course not. What it means is that they're probably both doing it, but it's not being investigated to see if that's the case. Only one study has ever been done, which indeed, and it was a small study, but it does show that the combination of the two are more effective than either one alone, and much more effective than a placebo. So there's very early evidence of that. We need to have more studies of that type so we can get through this problem we're now having. So the validity of the evidence-based data supporting the efficacy and safety of both psychotherapy and psychopharmacology still have a ways to go. But at least the ones with medications, the people have not been treated with therapy. They've been treated only with medications, so that what we've been able to do is tease out those symptoms that are more likely to respond to medications. Now, there are certain arguments, and this has been true since the first study was published, arguments for limiting the use or proclaiming there should be no use of medications for people with borderline disorder. And let's just run through there and see if it makes any sense to you. First of all, you don't burden the patient with possibly unneeded medications. Well, if they're not having any side effects, they could still have a burden that causes them problems later on. But the symptoms they're suffering from, which keep them in the hospital long-term or in a jail, I'd say that's a burden right now rather than a potential burden. So it's hard to argue that one as far as I'm concerned. Also, they prevent patients from unrealistic expectations that interfere with the work of psychotherapy. So if they believe that medications alone will do it, the concern is then they won't do the psychotherapy, which is essential. So I understand the problem, potential problem. The real problem is it doesn't turn out that way. There are some patients who do that, of course, but most of them don't. They're so pleased to be feeling better and to be able to learn things that they were never able to learn before that they engage very nicely in therapy. Of course, there are a group of borderline patients who refuse to be treated, but that's true of patients in just about every disorder, mental disorder. So in other words, it interferes with the therapeutic alliance. Now, again, that's not been my experience. I've treated now patients with borderline disorder for over 50 years. I've treated them at all ages but children. And what I see is that in most of them, they are relieved to find out what's wrong with them. And they're very happy that within a few weeks, some of their most disturbing symptoms are, for the most part, relieved. And rather than it interfering with the therapeutic alliance, they are quite appreciative to me or to other doctors who've made the diagnosis and certainly prescribed something that works quickly rather than over years. And then they can go on and proceed and benefit from the usual course of psychotherapy, which makes them even more closer to their full potential than otherwise. Now, what are the arguments for the use of medications? Well, it produces improvement of those symptoms that are significantly more genetically driven and responsive to medication than is psychotherapy. So it's obvious that you want to use that medication. Medications decrease the delays in therapy. If they're not treated, therapy is just going to take longer, and it may be totally unsuccessful and the patient drop out. And unfortunately, there is a high dropout rate from patients who are treated only with psychotherapy. That's rarely mentioned, but it's the case, unless they're quite mild in their presentation. And finally, it decreases the psychotherapy dropout rate, as we've just mentioned. So what's the most effective current integrated use of pharmacotherapy and psychotherapy? I believe it's something that I've come to refer to simply because it's easy for me to talk about it to other people and explain it to them so that they could try it, is a three-phase model. And that model calls in phase one for determining if their symptoms are severe enough to receive medications at all. Because some of the cases are mild enough, they don't need medications. Why would one use them? But for those who have a more severe case of the disorder, they need them, at least for the time being. So if they're given them, that's a good thing. And if they're not given them and they don't need them, that's good. So, but it doesn't take long for them, the physician and the patient, to recognize when medications have behaved optimally and when they're going to continue to respond better and better to psychotherapy. And that's phase two, where medications take a back seat and psychotherapy becomes the major treatment of choice and emphasis at that point. Other than when the patient has a borderline crisis, when temporarily they may need a little adjustment in their medication, especially in their antipsychotic agent, but a small one, nothing big, that quickly calms them down and they can be soothed and they can move on and back to appropriate therapy and behavior. The problem is that for reasons that are not clear, there are still many clinicians, maybe because they're not trained well in psychopharmacology, who continue to resist medication treatment for borderline disorder, as has been the case in psychiatry for other mental disorders, of course. But we've gotten past them. We still haven't gotten past that problem for people with borderline disorder. So if you read the literature, or just go to the website and dial up borderline personality disorder and look for treatments, you'll see probably 9 times out of 10, medications may be used, but they're certainly not placed at a very high level of usefulness, utility. And sometimes, even by big organizations, as in the UK, they're considered to be they shouldn't be used at all. That, of course, people who have experienced what I've experienced, and a lot of us have, think that's not a reasonable approach. That's why I said at the beginning, it's probably going to take a generation or two to get past the point we're at now. Now, let me see how we're doing with time. Do I have time for a quick case example that may take 5 or 10 minutes? Well,
sí, claro, doctor.
Since,
sí, claro, doctor. Tenemos muchas preguntas pendientes, pero sí, claro, doctor.
I need about 5 to 10 minutes to do a case example that I think will bring my point home more clearly. If it can't be used, you can always cut it out, okay? It won't hurt to have it down, recorded, okay? So
nos parece estupendo.
Let me go ahead and provide that and see. And again, you may want to use it or you may not. The patient that I have in mind was a young lady in her mid-20s who had started developing symptoms, not surprisingly, when she was in her teens, shortly after she pubesced, as a matter of fact. And before then, she had had problems too, but they weren't nearly as severe. She just got, her symptoms became more and more severe, especially her anger and her acting out. She became more and more that kind of person. And her parents were concerned about her. She did not demonstrate any concern herself. She thought that was perfectly appropriate behavior. Not surprisingly, she became sexually promiscuous and developed a sexually transmitted disorder, which had to be treated. Fortunately, it could be treated. It was one of the ones that were treated. But from that point on, the family were really very concerned. And so they looked around to find out what was truly going on with this girl. And she eventually got into my hands, and I diagnosed her as having borderline personality disorder. And I started her on medications and essentially used the three-phase model. In the beginning, we used mainly medications, although we were supportive and did that kind of therapy. We really didn't dig deeply into the origin of her environmental problems until she was doing better. When we reached that point, we were able to start treating her with more intensive psychotherapy, and she responded again, additionally to that. So she was getting better and better. However, at one point, her father died, unfortunately, right in just about the first third of phase 2. She wasn't really ready for that loss. And she developed a significant depression. And after a while, the therapist sent her back to me and said, I don't understand it, but she's now very, very depressed. And what used to be working is no longer working. So when I heard the story, what I thought was, well, this is not borderline disorder. This is what she's suffering from is a typical manic, not manic, but major depressive disorder, and which is comorbid. About 50% of people with borderline disorder will develop a serious coexisting depression during the course of their lives. They'll also develop 25% of them will develop ADHD. A large percent of them will develop substance abuse, close to 50% again. So they're at risk for secondary illnesses, and you have to be on the lookout for them, or else you're thinking everything's borderline, which it's not. But you have to have stabilized the borderline before they respond well to anything you treat them with for the secondary problems. So I started her with, I explained to her what was happening to her. And by the way, when I first started her on the medication, or attempted to, she said, I really don't think I want to go on medications. And I asked her, as most patients do, respond, why not? And her response was, well, I just won't be the old me. I'll change, and I'll never be as good as I was before. My response to that was, actually, no one knows how you were before. No one has ever seen the real you. The real you is still there. It's been hidden by all these symptoms. If we treat the depression, and we have treated the borderline disorder, you're going to get past those, and you're going to find out how really good you are. You're going to be able to study. You're going to be able to work. You're going to be able to interact with people pleasantly. So all the problems that you used to have, most of them are going to be markedly reduced. So if I were you, I would say, thank goodness I'm not going to be the person I was before. That's what I came in for treatment for to begin with. She accepted that and went on and took a treatment for borderline disorder, and then was really willing, of course, with the success that was achieved there, was willing to take her antidepressants, and within the usual amount of time, she responded well to that. That completes this part of the presentation. The final part of the presentation would be questions and answers, but this is being videotaped, and I'm not sure at the moment how that will be handled. But I'll when we finish with this, then I'll find out. If indeed it does not involve me anymore, let me say once again how pleased I am to have been with you today and to share my experiences and the current status of borderline disorder in the United States with you. If you think that you're way behind the United States or any other country, I don't think you need to worry about that. If you focus on the kinds of things we've discussed today, I think that you'll be doing just fine. There are a number of books, by the way, that can help you. Noticing a number of years ago that there was no book written by a physician who had treated many patients with borderline disorder. I wrote a book that was published in 2004 and was just updated in 2018. And it's called Borderline Personality Disorder Demystified. And I'm working to help the foundation appropriate a number of copies of that so that the members of the foundation, patients, family members, and the staff have access to some reading that may be important for them to get their hands on. All right. I wish you all well, good health, and a very happy holiday season and a successful and healthy new year. Goodbye.
Claire, si le puedes decir, te lo agradezco, que ya tengo los libros, que ya uno de los psicólogos ya lo ha empezado a leer y que estamos súper agradecidas. De hecho, es este libro que te estoy enseñando en pantalla ahora mismo, Claire.
Ah, good. Now,
Many thanks.
can someone translate that for me? I'm glad you have it. Can someone translate what Teresa just told me? We don't have a translator there yet, huh?
Gracias.
Okay. Well, I'm glad you have a copy or two. If you need, I'll be happy to arrange to have get more to you. And
Es un placer el haberle escuchado.
if there's a big demand,
Díselo, Claire.
I can get them for you at half cost. They typically give the author a significant cost on any size order, which I think is very nice of them.
Vale.
And enables people.
Gracias, Claire.
Yeah, that's good. Well,
Creo que te va a hacer alguna
Muchísimas-
pregunta, Patricia.
Sí, muchísimas gracias, doctor. La verdad es que ha sido una ponencia muy ilustrativa, sobre todo poniendo encima de la mesa las alternativas terapéuticas que disponemos y en las que tenemos que ir probando también. Me parece muy interesante, es verdad, que no solo con fármacos, sino que la psicoterapia es un apoyo fundamental en los trastornos por salud mental. Pues tenemos, la verdad es que muchas preguntas que nos han salido. La primera, por ejemplo, doctor, le quería decir, ¿cuáles son las causas o los desencadenantes de un TLP y el origen, si suele estar en situaciones un poco vividas en la infancia? Nos pregunta un lector.
Well, I wish I could have understood that, and maybe someone will include a quick summary of what you both said in a short document that you could send to me. I'd like to read it. Again, it's been a really great pleasure working with you.
La pregunta, perdone, doctor, la pregunta es, ¿cuáles suelen ser las causas o desencadenantes?
It says if I click here that I can get an
¿El origen suele estar en situaciones vividas en la infancia?
Do you have an English translator available? No? Okay. Well, with that, I will sign off and thank you again for all of your help and inviting me to do this program with you. All right.
¿Se lo podemos decir al doctor esto, por favor? Hi, doctor. Can you hear me?
Yes.
Yeah. Are you available to check if you select the English language or in the toolbar at the bottom of Zoom?
Carlos, I didn't catch all of that. Could you repeat it, please?
Sure, no problem. So you have to check that you select the language. In your case, I think that this should be English. You can see that in the 3 dots.
Yes, I just clicked on that.
Okay.
Recently. Okay.
So
I guess that's how you came in to it. I don't know, but all I would request is if the Teresa and the other person who's on board with you this morning wanted to repeat a little bit of what they said, I truly I'd like to hear it. It'd be very disrespectful of me not to. Can you tell that to them? We still have some time.
Vale, Claire, ahí te va. ¿Cuáles suelen ser las causas o desencadenantes de un TLP? ¿El origen suele estar en situaciones vividas en la infancia?
Carlos, can you translate that for me?
Sure. Well, Claire, can you translate that, please? Are you available to do that?
Am I able to be back again? Is that what you're asking?
Yeah, doctor, you have to select the English language in the 3 dots. Please, yeah.
I'm not quite sure. Maybe you could put that in an email.
So in the 3 dots, you have to select in the interpretation or language.
Collect the questions.
Yeah, so you have
respond to the questions in writing.
No.
How would you like me to respond to the questions?
Yeah, you can respond in English.
Yeah, but on you know how set up another video. How would that happen?
Okay, no problem, doctor. We are going to send you these questions by email. So we have already the emails from the people that are asking all of these questions.
Yeah. And what is it? They put it in writing.
So also for the other speakers, we are going to do the same thing. We have a lot of questions.
Yeah. How
This
can I
was
answer
amazing.
those?
So yeah, no problem, Dr. Friedel. I will send you by email all of your questions.
Yeah, we can work that out. We can work that out by email, Carlos.
Next speaker, if you don't mind. Really appreciate your participation here, please.
I find that some of the
stay with us because we have 30 minutes more. So really appreciate your participation here.
Because you were going to contact me with the questions by email.
Yeah, that's right, doctor.
Okay. Well, look, I'll be happy to respond to the questions any way that you think is appropriate and helpful, because in my experience, the most important part of a presentation such as today's is the interaction with the audience, because they're asking me questions that I did not address during the presentation, and for them those are important. So I want to be able to deal with them directly.
Absolutely.
So that's why in English I can, and if I'm there in person,
problem. We are going to
I can do that.
All of these questions. Okay, doctor. Thank you.
But I'd be very happy to do it. Very happy.